Previous speakers have made my job much easier, so I don't really have to go into too much of detail as far as introduction is concerned, and we'll make it as fast as possible. These are my disclosures. We'll start with basically a case-based approach. This is a 28-year-old male who had a lateral wall MI 15 minutes earlier, was shifted to hospital, was fairly stable when he came to hospital, almost no discomfort. His ECG was all right. Echo showed some 45% EF, as a little bit of RWMA in the lateral wall. But within minutes, his angina worsened, and his repeat ECG was this. His LV function dropped to 15%, his pressures crashed to 80. This is what his angiogram was. Notice that the heart rate hasn't had the time to go up, so it's how fast we managed to shift him to the lab from the emergency, and you can see the entire left circulation. This is what it was like. This is another patient who had an out-of-hospital cardiac arrest, was carried to the emergency by bystanders. The code blue team was evacuated. He was shocked back into some rhythm, EF of 20%, taken to the lab on double inotropes, and this is what his angiogram was like. This is an 82-year-old with chronic stable angina for 2 years, underwent an angiogram a year ago, was advised surgery, refused the same, again came to emergency with ongoing chest pain, with borderline pressures, but a normal ABG, global ST depression, and we had to put an IBP just to stabilize him, and this is what his anatomy was like. And the pressure was stamping, so the guide was dehooked. This is another 81-year-old lady who had presented with shock and severe MR, undergone a POBA to the ostial circumflex, which was 99% occluded. But then some flow came back. Nothing else could be passed into the circumflex after that. After 2 days, she was taken to the lab, and this is what her angiogram was like. She'd been refused surgery because of frailty, and the patient did not want surgery as well. And the surgeon also didn't want even to look at the patient or touch the patient with the barge pole. This is what her anatomy was like. This is another 34-year-old who was brought to us, air evacuated to us with ongoing chest pain. And this is what his angiogram was like. The 62-year-old lady who recovered from an NSTMI about a month ago, and one episode of heart failure, stabilized and angiogram done with an LVED of about 35 or so. And this is a 61-year-old male, hypertension, dyslipidemia, chronic stable angina for 2 years, with RWMA in all 3 territories and EF of 35 to 40%, but all territories had preserved thickness, and this was his calcified coronaries. Now, all left main disease is not the same. All clinical situations are not the same, and it's a daunting task to try and summarize everything in a 15-minute talk, but we'll do what we can. We've already spoken about this. Who is a CHIP patient? We're going to look at strategies and my approach. This is the study which has already been presented. In simple terms, 7 patient factors and 6 procedural factors in a multiple logistic regression analysis actually predicted outcome, and this was validated when this was reapplied to their own population of 300,000 patients. They were associated with increased in-hospital major adverse cardiac and cerebrovascular events. This is the cumulative score that we have spoken of. There are many scores for surgical risk, but none really focused on PCI. There were attempts made with the Jeopardy score, etc. But this is the first and large validated scoring system which has been designed. The syntax and syntax score actually focus more on PCI versus CABG. Primary PCI and shock have been excluded everywhere, as has been discussed. The CHIP score focuses on the risk rather than on the complexity of PCI, and this is an important concept. Thus, in a particular patient, a type A lesion with multiple comorbidities and multiple risk factors may actually be higher risk than somebody who has a little more complex anatomy but doesn't have these high-risk features. And this is an important concept to take with us when we put a patient on the table. As far as the LM and the ACS, this is a completely different entity as far as ACS is concerned. There are only 2 questions to answer. Is the patient already in shock when he's got an LM with an ACS? Is it possible that shock will occur during the PCI? The CHIP score is meant for chronic coronary syndromes, and the presence of LV dysfunction and left main disease straight away puts him at a very, very high end of risk. The shock classification is important because it's a quick assessment which can be applied at the bedside. Anybody who has clinical evidence of hemodynamic instability where hypoperfusion has already occurred in terms of an elevated lactate, a drop in renal function, or a drop in creatinine clearance, worsening LFT is already in class C, which means the first priority should be towards stabilizing this patient rather than taking him to a lab for a PCI. Anybody with class B means you can actually go ahead with the PCI and keep the support on standby, and this is again an important concept to have. Again, I summarize stage C and beyond, first assist the LV and then take him to the lab. Whereas stage B, consider LV assist early, but you can't go ahead and take him to the lab. Right heart cath is invaluable in deciding what you're going to do. Off-label in our centers, we are using right heart cath continuously. We put in a PA catheter, we monitor the pressure continuously, and we use infusions into the PA. This is not, this is off-label pretty much, but nitroglycerin infusion into the PA is a fantastic way of extending the time to which the patient is likely to crash when you don't have LV assist available. So when we look at a left main, technical considerations as far as the left main PCI is concerned, 5 to 7% of all left PCI contains left main disease, 75% of bifurcation. These figures are important, more than mean of 4.78 in Western data. Diffuse disease is an issue, and imaging gives us important sizing inputs. Historically, from 78, multiple operators have looked at left main, but it has remained a problem as far as intervention is concerned. The newer trials, Excel and Noble, tried to kind of risk stratify and decide which is better. They have been criticized for their, PCI bias, but it's important to look at the figures. Even in Noble, in 5-year mortality, there was no difference. And we were looking at 28 events in the PCI subgroup versus 19 events in the CABG subgroup. And I think the amount of literature that has been written on this difference of 28 and 19 is probably in volumes. But it's important to actually look at the absolute figures. We're looking at 11 different events over 5 years in 2 groups of 600 patients each. Just put it in perspective. When we look at meta-analysis, 4,200 patients, 1 stent versus 2 stent, the MACE, TVR, TLR, and ST among the 2 stent techniques was almost equivalent, and meta-analysis was actually lesser. DK Crush and Mini Crush actually had a reduction in MACE, TVR, TLR compared with provisional, especially when they were stratified for complexity. Culotte and Crush had increased stent thrombosis compared to provisional in the earlier studies, in the first generation stents. The EBC main looked at 467 cases in 1:1 randomization. There was no difference, but only 1/5 of the patient in the provisional group actually had a second stent requirement, and the mean syntax was 22. So these were very, very simple patients as far as procedural complexity was concerned. The questions that we need to look at: do we need to do it? Do we need atherectomy? Do we need imaging? In today's world, the third and the fourth question, I think, have been answered. We should be using imaging, and we should be using it before as well as after stenting in every patient where it's available. What about assessment? What is the problem? How do I do it? Performance, hardware and software, and assessment post-procedure, follow-up and learning. Assess the patient, assess the clinical situation, assess the anatomy. Do we need hemodynamic support? And do we need special techniques? These 5 questions will answer exactly what all we require to have in the lab at the time of doing the left main. Prior to the assessment or prior to deciding, this is the algorithm that we would follow. Look at the angiographic left main. If it's more than 70%, he needs revascularization in a symptomatic patient, and he'd straight go to the heart team assessment. Between 30 to 69%, we look at imaging and physiology. If are favorable, we go ahead with optimal medical management. If there is any doubt, we go in again and look at the heart team discussion. If it is prohibitive or unfavorable risk for surgery, we look at PCI procedural risk and then decide what we're going to do. FFR for left main has some fallacies because downstream disease and the presence of disease in the other vessel will decide how significant this is going to be. And it's important to know that once one has an FFR resting of less than 6.5 in the circumflex, the FFR interrogation down the LED becomes unreliable as far as the left main disease is concerned. And this is an important concept to have. The imaging options are 2. We know the differences between them. The magic number is 4.8 to 6. There may be lesser interobserver variability with OCT, but we are looking at data. In our study, volumetric full segment analysis is better than cross-sectional analysis, and we are looking at working out on some technique to try and formalize this. If the equivocal FFR is equivocal, then the imaging comes to our rescue. If we have shaft and bifurcation disease, OCT scores, LM ostium disease, IVIS scores, although there are ways to get around it. We look at the morphology, the lesion length, landing zones. We all know these algorithms. The fallacies of imaging of angiography are all overcome by imaging. The short left mains, the obscured lesions, the overestimation, the catheter spasm, underestimation due to diffuse disease, etc. Tissue penetration and characterization of calcium is better with OCT. Stent selection is very, very important in this particular subset, and it's best to choose a landing zone with a lipid-free area, intracoronary nitroglycerin. Stent optimization, edge dissection, tissue prolapse, malapposition, all these are important. Post-stenting follow-up is a relatively unexplored area. After we have finished with the left main angioplasty, at what stage do we need to do the follow-up with our imaging? And there is a lot of potential for data generation in this particular subgroup. But it is invaluable. I am speaking of the long term. What happened to our patients? This is our 28-year-old male who quickly underwent a wiring of both the vessels, thrombosuction, and a straight crossover stenting. Quite simple, straightforward. He had AIVR, which lasted for an hour after that, and everything recovered as far as his LV was concerned. He's on follow-up for the last, this is a 7-day follow-up, then a 1-year follow-up, and then a 6-year follow-up, and he's doing absolutely fine. This is our second patient for whom we had done multiple runs of thrombosuction, then a balloon inflation. And we left a stent position in place, and we just did a conventional crush. We'll quickly run through. These are simple cases for all of you. Therapeutic hypothermia we used, and we had follow-up at the end of 3 months and 1 year. He's on follow-up for 8 years, and he's doing absolutely fine. He's had a follow-up angiogram at 4 years. This is our 82-year-old male who had an IABP placed. This was his distal left main. After we got consent, we then went ahead and put in a wire with a microcatheter, did a rotablation in segments, 10 millimeters each, and then polished the whole thing. Went ahead, saw that there was no perforation, did a single crossover stenting after dilating with an angioscalp and a cutting balloon, a long segment non-compliant balloon, dissected the LED, which we're very happy about because this means that our stent is going to expand, did a nice pot, rewired the OM, did a small kiss, and finished with a single crossover stent. Repotted it, and that looks perfectly good. This was our cardiogenic shock, and this was a pretty bad case to do actually. This was the angiogram as we have seen. So we first wanted to secure the LED, that's what we did. We wired it and rotablated it, and then did the single most important thing in this case, that is we did a good quality imaging. The OCT run was invaluable after the rotablation because it showed us the reference diameter, and it also showed the cuts in the mid to distal LED, but that the proximal LED was full of calcium. The depth was more than 1,000 millimeters. It was completely, it was concentric, and there was a huge nodule at the mouth of the circumflex which would have prevented any hardware from going in. So after we fixed the outflow of the LED because of the dissection caused by the rota and the balloon, we then went ahead, wired the circumflex with an XTR, put in a microcatheter, put in a rotablation, and then did some little bit of challenging rotablation burring. This is a technique that we use sometimes when you are faced with a very, very angulated circumflex or a retroflexed circumflex. We do a half in, half out. We leave the burr there for a good time of about 20-25 seconds or so before you finally manage to cross. And you cross by yanking or pulling on the wire a little bit and advancing the burr. We finally managed to cross with the rota burr onto the circumflex. You can see that after we have managed to cross, then we put in the microcatheter back, put in a support wire into the LED, went ahead with the IVL because we needed to do the IVL, otherwise nothing would have expanded because of the amount of calcium there, to the LM, the LED, and the proximal circumflex, a kissing balloon, and then finished with a DK crush, which as everybody will know. So I'm just going to run through the cases and reach the rest of them are pretty much the same. Ajay, there was just another learning point in which I wanted to show the importance of how imaging in between the case actually helps you. We'll just go to the end. It was actually a DK crush in which we had finished with the stenting, but we were unable to do the final kiss. And the OCT was invaluable because we are very, very gentle as far as the balloon dilatation is concerned. The OCT showed us that we were absolutely fine. We just needed a little more force because it was a long left main, and we had no problem in finishing off the case. So in summary, and that was our final result for the calcified left main bifurcation. CHIP score anything above 3. We have to be careful. One stent wherever possible. Complex left main bifurcations are always better with a 2-stent planned strategy. Choose the strategy best suited to the patient, anatomy, available resources. C, cardiogenic shock is always LV assist until proven otherwise. Protected PCI if one has got long procedure and LV dysfunction along with left main disease. This is a deadly combination. IABP gives approximately only 0.5 liters per minute cardiac output additional. But if that's the only thing that you have, this is what we're going to use. This is the central illustration that we use for decision making, Chen's illustration. It is absolutely superb and has served us very, very well. Whenever one has longer than 10 millimeters lesion length in the side branch, it straight away becomes complex. A simple lesion plus multiple bifurcations, thrombus, reference vessel diameter 2.5, a main vessel lesion more than 25, calcification, angle less than greater than 70 or less than 45. Any of these two makes it a complex lesion, and it's better to go ahead with a two-stent strategy. Meticulous planning, puncture to closure. Plan the strategy, play out all the steps in your mind and rehearse them once before you actually put the patient on the table. Choose your hardware well. Whatever hardware has the best chance to cross in the first attempt. There is no point in trying to take, let me see if this goes. Choose the hardware in a way the hardware which has the best chance to cross in the first attempt. Every patient with LV dysfunction, please do a right heart cath. This is what we do in our center. We would always measure the PA pressures. Plan B for every step. Don't be hung up on DK crush. If you want, you can change depending on what you find on that particular day if it doesn't go on that way. Teamwork, as has been emphasized by Dr. Sarita, I think is absolutely essential. Every step should have a standby and a backup. It's good to delegate the heparin, the ACT, the hemodynamics, and the ECG to 4 members in the team and give that responsibility to them. Another pair of eyes on the screen are absolutely important and absolutely mandatory whenever one is doing a chip score. In fact, we are trying to form teams, and I think that is one thing which is going to enhance safety in our lab. Imaging is invaluable. OCT or IVUS, wherever feasible for left main. Obtain and interpret with a colleague. Sometimes just discussing what you see on the screen in those 30 seconds that you need to make a decision is going to get you to a better place than you were before. Anticipate and prepare for a crash. That means there's no point in doing everything after that. Anticipate it and prepare for it. Do a right heart cath. It will always tell you whether your patient is going to tolerate a long procedure or not. A PA catheter with an infusion of NTG is a simple way to extend the time to the crash. Once you put in a PA catheter, you can start NTG at low dose, and it's going to bring down your PA pressures and stabilize them. It will give you a little more time extra to work. Insert a sheath for IABP before. If the possibility of a crash is anticipated, just take the puncture before. Trying to puncture in panic when the pressures are low and you're going, you might hit something and then end up with a bigger complication. Consider an Impella whenever available. Consider an ECMO if your procedure is going to be long, the LV is good. ECMO is a bad option in case the LV-ED is high and the PA pressures are high, because it's going to load the LV more and it's going to worsen the situation. It will protect your kidneys and your brain, but it's going to make the heart very bad. So in patients in whom the procedure is going to be long, you want to do a complete revasc at one go, and you feel that the heart LV-ED is not very high, ECMO is not a bad option. Tailor the strategy to the situation. In a stable patient, try to give the best long-term result. In an unstable patient, it's important for everybody to get out of the lab alive. Keep it simple is the strategy. Never is there only one strategy for all. Image wherever possible. And thank you for your attention, and I should be glad to answer any questions.
Thank you, Dr. Ajay. It was an exhaustive coverage of the topic. Now a short question to you. When the left main presents as chip, you have said you have approached in totality to the left main usage of imaging, usage of functional assessment, plaque modifications and the types of stenting and all that. Do you keep a slightly different pattern of approach in LM with chip versus LM with a usual situations? Like, stenting technique, will you go for complexity of two stenting, or if you could get away with single stent, you will do that, or you will avoid for the procedures of using a lot of devices in addition and get the patient out? What is your approach in general, so that they go with an idea?
Yes, sir. It's a great question, and it is very difficult to give a simple answer. We are looking at two situations. If you are looking at an acute situation, the aim at that time is to get the patient out alive. So if I have flow into the side branch and I have a good main vessel flowing, I think you can always bring the patient back at a second, because sometimes you don't have access to whatever LV assist you want at that particular time. If LV assist is available and it's on board, then you can be aggressive and you can go ahead and get a good result, because there is no requirement to pull it out immediately. You can leave it in place for some time and the patient is going to stabilize thereafter. So that's the first situation. The second situation, in an acute situation, if the right heart pressures are good, I would still try to get as good a result as possible on the table as not. Everything depends on the judgment which says this patient will tolerate this much, this patient will not tolerate this much. That is going to decide how complex you're going to be. At the same time, you cannot walk away with any vessel which was flowing at the beginning, not flowing at the end. If it was flowing TIMI 3 at the beginning, it has to be flowing TIMI 3 at the end. And that is the aim that every intervention you have to predict for and you have to plan for and you have to protect those vessels, etc. It's very difficult to give a very comprehensive answer. I hope I have tried to.
That's why I said if you have the hemodynamics is under your control,
Yes.
support. Say if the patient is on an impella and a complex case, you should see that at the end you go to that.
Absolutely happy. Yes.
Otherwise, the rectal grievance and procedures are more. Even using all the devices like imaging and then functional assessment and getting a perfect result at the end is essential.
Yes, absolutely.
Thank
Absolutely.
you very much. Any other questions from the...
Sir, we have another 2 more minutes for discussion. Just a point on this routine PA pressure monitoring. Well, do you decide on PA pressure monitoring based on the LV function and hemodynamics or any sick patient? How do you exactly decide?
So we use
good LV function, a patient who has renal impairment. Those situations also, would you prefer going for a PA catheter or you assess the hemodynamics, LV dysfunction, then decide on a PA catheter? Second point is regarding PA catheter. How do you put in? Do you have the PA catheter inside the cath lab or do you have it pressure monitoring in the ICU? Shift the patient to ICU, have the catheter in, then shift the patient to the cath lab. What is the dynamics like?
Great question. So if you have LV dysfunction, we will always put a PA catheter. Now, in addition, if you have normal LV function and you have a simple procedure, then no PA catheter is required, even if the patient has, a little bit of renal impairment or so. If the LV function is normal and you're going in for a long procedure, then also we would use a PA catheter. And for I hope that is clear. Every patient with LV dysfunction, we would like to put in a PA catheter. The catheter that we use in the lab is actually an MPA because all you need to measure is the PA pressure and the PA wedge. And it can very easily be wedged to get the pressure. You don't need to continuously monitor the wedge. You just need to measure it intermittently. The reason we use the PA catheter is, the MPA catheter is because you can give infusions of drugs through that and you can connect it to an infusion pump and it's very, very easy. We always do it in the lab. We don't put in a PA catheter in the ICU at all. This is different from a patient who's got established cardiogenic shock in which you're going to bring him first, stabilize him and then bring him, in which case often that might be the case, that you might have to put in a PA catheter in the ICU and then bring him. I am speaking of the pure intervention patient who's at risk of dying, by definition, Chip.
Sajid?
Yeah, a wonderful talk and I think you covered extensively. One of the important challenges we get stuck with is a left main disease with an RCA CTO. So what is your take on that? Do the left main first or do the CTO first? Because retrograde becomes a problem.
Yep.
Your microcatheter will occupy most of the lumen of left main if you have to go retrograde. So we are faced with that many times.
So if it is a large and a very, very dominant RCA and the CTO score is small, I would still try to do the first revascularize the CTO. But if the CTO is bad and it's more than 20 millimeters long and I'm going to do a retrograde, I will never do a retrograde with a diseased left main. I would always fix the left main first because it's not all that difficult or all that challenging. If it is really challenging, then I would consider an LV assist and then go and finish the whole job at one go. I mean, that would be my decision-making matrix.
One thing, nothing to do with Chip or your cases. One problem I faced 2 days before was this patient, 45-year-old male, came with severe chest discomfort, troponin positive, ECG almost same as you have already shown. I went to the lab with the intention of doing an LM, but the coronaries were normal. So later echo showed a dilated RV and it was an acute pulmonary embolism. And I missed it. It was maybe then only I referred the literature. It is well reported. Maybe I was not aware.
Don't feel bad, sir. It's happened to all of us.
Thank you.